Hi, everybody. This is Tiffany Cook with Cure Duchenne Cares. We have someone on the line today that we're going to ask a few questions to. As you know, I have a 19-year-old son with Duchenne, so a lot of these questions are kind of things that I've been looking for answers as well. So I'm proud to have Dr. Hank Meyer with Children's Hospital of Philadelphia on today to ask him some of these pressing questions surrounding COVID-19. Thank you, Hank, for joining us today.
You're very welcome.
Hope all is well there in Philadelphia.
Yes, happily quarantined.
Like all of us.
Socially isolated, not quarantined.
Yes, yeah, for sure. Well, I have a few questions for you, so I'll just get us started off. First question up. So how does COVID-19 affect lung function?
So what happens with COVID-19 is that it causes an inflammatory reaction in the airways, and that can lead to seepage of fluid into the airways themselves. It's called pulmonary edema. And in the most severe case, it leads to something called acute respiratory distress syndrome. And that's where patients end up needing invasive mechanical ventilation, meaning they have to have a breathing tube placed. So that is how it affects the lungs. Specific lung function, as in what we get from the pulmonary function testing lab. We don't really have data on that, but presumably what you would see is a worsening in airway obstruction and then a loss of lung volume.
Next question. Does COVID-19 affect muscle function?
That's a very good question. If you think of severe viral infections like influenza or adenovirus, the typical seasonal respiratory viruses, they can cause muscle weakness during the height of the infection. But in terms of muscle damage, I'm not aware of that being an issue.
Are there special considerations my care team would need to be aware of if we need to seek treatment for COVID-19?
The most important single thing, in my view, for managing a patient through a COVID-19 or any other respiratory viral infection is maintaining airway clearance and increasing it based on the need. And I say that because for patients that have a fully intact cough, one of the things that we do right as we begin to get sick is we start to cough because we have more respiratory secretions. And so for somebody that doesn't have an intact cough, whether it's from muscle weakness, as is the case in muscular dystrophy, or because of an inability to recognize when one needs to cough, it's critical that caregivers increase airway clearance right at the earliest possible stage of an acute respiratory infection, be it COVID-19 or influenza.
Can a patient with Duchenne who has mild symptoms with COVID-19 be treated at home?
Absolutely. Again, mild symptoms. The recommendation for seeking care in the hospital for anyone is when you are beginning to have difficulty breathing. The concern is that that would be an indication that the inflammation in the lungs has gotten to the point where it's affecting the ability to bring in oxygen and remove carbon dioxide. And if there's a subjective sense of difficulty breathing, then I would definitely come in. If there are symptoms that would go along with a general respiratory illness, fever, a little bit of a cough, as long as they're mild, you could certainly manage at home. But I wouldn't wait too long before seeking medical care.
How quickly can the symptoms of COVID-19 change from mild to severe in a patient with Duchenne? Does age matter?
I'll break that into two questions. The rapidity of progression is probably in part related to the what we call the viral load, the dose of the virus, if you will, that the patient was exposed to and has developed. Beyond that, if you have a weakened immune system, which isn't obviously an issue for the vast majority of patients with Duchenne muscular dystrophy, then the infection can progress quite rapidly. Um, Within the under 40 age range, not really. There's a little bit of a decrease in incidence under 25 and certainly in the teenage years, but patients 40 and under are still well within the range where the infection tends to be on the more mild side relative to the elderly or the population above 60.
There's been a lot of concern expressed about the potential of a ventilator shortage. If necessary, can a CPAP and or a BiPAP machine be used to help like a ventilator?
Well, let's just start with basics. So CPAP, continuous positive airway pressure, is not a ventilator. A ventilator is a device that gives you a higher pressure when you breathe in and then lowers the pressure when you breathe out so that you can get more air into the lungs. CPAP is just used for obstructive sleep apnea, which some patients with Duchenne muscular dystrophy certainly can have. But for supporting somebody during acute respiratory failure, you can use a BiPAP unit, which stands for bilevel positive airway pressure. And a BiPAP unit is actually a ventilator. The difference between a standard BiPAP unit and what we use in the hospital is that the devices we use in the hospital are a bit more robust and made to be used continuously. Some of the ventilators that we use at home can be used continuously. But we often start with regular BiPAP units that are just made for nighttime use. So in summary, you can use a BiPAP unit for ventilation, but not a CPAP unit.
I know some families whose sons have a cough assist but don't use it. If the child with Duchenne who has a cough assist and began using it now, would it help him if he were to get COVID-19?
Absolutely, and that's the most critical component of managing any acute respiratory infection, whether it's COVID-19 or any of the other seasonal respiratory viruses. And I can't emphasize this more. The other issue that I just want to point out is that one of the concerns is in preventing transmission of somebody with suspected COVID-19 to other people. And there are things that we call aerosol generating procedures. Coughing is an aerosol generating process. If we do airway clearance maneuvers with the cough assist or with IPV, intrapulmonary percussive ventilation, or nebulization, those can also be aerosol generating. Now, the issue comes into play in the hospital where you have to try and protect healthcare workers as much as possible. And so some hospitals have guidance recommending minimizing the use of airway clearance devices like the cough assist or IPV. And that's the absolute wrong thing to do in the acute phase of an infection like COVID-19. And so what many hospitals have done have recognized that until we have a COVID-19 negative result, we need to treat the patient as if he has COVID-19, which means putting that patient in high-level isolation until the testing is determined to be negative. That is an absolutely mandatory step in the acute management in the hospital. The option of not doing airway clearance for a period of time until COVID-19 testing is negative is an absolute it's completely unreasonable and not something that should be allowed or considered.
How often do you recommend using a cough assist? And what if the patient contracts COVID-19?
That's a very good question. The simple answer is, how often do you cough when you get sick? And the answer is as much as you need to clear your mucus. What we typically will do with our patients when we start them on a cough assist is say to do it twice a day routinely, just to help keep the lungs clear. and then during an acute illness, increase to every hour as needed. Now, beyond that, there are times when we have a family that might call in and say, my son or daughter has difficulty breathing, has more secretions. And what we may do is say for the next hour, do it every 10 minutes. And so there's no practical limit to how frequently you can do the cough assist when you're sick. It really depends on the amount of mucus that the patient's producing and the difficulty or lack thereof of removing it.
What about cleaning our equipment? Should we be cleaning it more often or using anything special for cleaning?
Well, cleaning the air filter in the cough assist or the ventilator routinely is important. And each medical equipment company or manufacturer of respiratory equipment will have a way of doing that. Now, because I mentioned that airway clearance and actually ventilation, such as BiPAP or even CPAP, is felt to be aerosol generating. And so the idea that we have during this time is not only to clean as much as we can, but also to limit the use of humidification systems, which would decrease the likelihood of aerosol production. So I don't have a frequency of cleaning that I can propose, but I would certainly follow the manufacturers or the medical equipment company's recommendations, and perhaps err on the side of doing a few extra, cleaning perhaps a little bit more frequently than normal.
Are there certain pieces of equipment we should be aware of that are often overlooked when it comes to cleaning?
The only two, well, I guess 3 pieces of equipment that really you need to pay attention to would be the airway clearance device, whether it's the cough assist or IPV, the nebulizer if you're using one, and then the BiPAP unit, the ventilator. Other than that, feeding pumps or anything related to that, I don't know would need to be cleaned any more any more regularly than normal. Just really the devices that would be in direct contact with air coming out of the lungs and respiratory secretions.
Well, that's the ending of my list of questions. But before we close, are there any overarching comments or statements that you feel are pertinent for this community?
Yeah, I mentioned this in the middle of one of my previous comments, but the most important single thing at the beginning stage of any respiratory infection, whether it's a bacterial infection, pneumonia, or a viral infection, bronchitis, bronchiolitis, COVID-19, is airway clearance, and doing it frequently and not cutting back on it. And as I mentioned before, there's some guidance that I think is sadly misguided, that airway clearance should be limited during the acute portion of a suspected COVID-19 infection. And this guidance is based on an attempt to try and minimize aerosol generation of COVID-19 and minimize the chance of transmitting it elsewhere. However, for somebody with airway clearance deficiency, that's the absolute wrong approach. And the issue is that if you delay aggressive airway clearance, then you're going to extend and make more severe the acute illness that comes from the COVID-19 or whatever respiratory virus you have. So aggressive airway clearance is still absolutely critical and needs to be done without any limitation, whether that means placing a patient in high-level isolation or not. That's determined by the institution. But if that's what it requires, that's absolutely what needs to happen.
Thank you so very much, Hank. I really appreciate your time today, and very, very thorough information. I learned quite a bit, so I'm excited to share this content with the rest of the Duchenne community. So very, very helpful.
Okay, well, good luck to you and to your family, and I hope you all stay healthy and well.
Thank you. You as well. We'll be in touch soon,
Okay.
I'm sure.
Okay. Take care.
All right. Take care. You too. Bye-bye.
Bye-bye.